Let's study something until you become a neonatologist. Okay, so you have an infant born to a mother with no prenatal care. You go to the delivery, infant is clearly in respiratory distress, has a scaphoid abdomen, and you intubate right away. Having some difficulty ventilating, take the kid to the NICU, get an x-ray. Of course, we're reading our own images, and you get this picture. So start with your airway. You're looking for your ET tube here. This looks like the trachea and looks like there's been pushed completely to the other side. But your ET tube looks like it might be in the right place. Hard to see where the carina is. This is an NG tube, and that seems odd. It's going in the wrong place. But what is this? That's bowel. This is a congenital diaphragmatic hernia. This occurs very early in pregnancy. The pleuroperitoneal membrane is forming, usually completed by week 12. And if there's any defects in that, there'll be a defect in the diaphragm. The size of the defect can be different. So you can have a left-sided, which is the most common, a left-sided defect, or a right-sided. If there's liver involvement, that's typically a worse prognosis than just some of the intestines on the left side. Interestingly, you don't just have lung hypoplasia on the side where the hernia is, you actually have it bilaterally. If this is diagnosed prenatally, there are calculations we can do to predict the long-term survival and morbidity associated with the type of defect and the size of the defect. Depending on the size of the defect, there is an option for a prenatal procedure. This surgery is pretty amazing. They put a balloon into the infant's trachea. We know that amniotic fluid is essential for lung growth. So by blocking the fluid from coming out of the trachea, that amniotic fluid can then expand the lungs and help them grow in the meantime before the infant is born, giving them a better shot of survival. So in residency, I had a CDH, but it was in a baby that was like maybe 4 or 6 months old. She came in, her siblings were sick. She was diagnosed with RSV. I went to examine her before she came to the floor, and I really didn't hear breath sounds on the left side. She was looking a little bit worse than what was described to me, so I got an x-ray. And it looks something similar to this kind of big bubble. So initially we were thinking maybe a pneumothorax, so called surgery, who came, looked at the x-rays, agreed. They were going to take her to the OR for a chest tube. They repeated the film with an NG tube in this time. They saw that the NG was coiled in the stomach in the lung field. So although it's more common in the newborn period, you can see it present later in life, especially in a scenario like this when there's a small defect. So always do your physical exam, trust your gut, get the imaging if you need, but keep it on your differential.